Good evening and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for the Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for this evening is, what was that? Differential Diagnosis of Epilepsy. And we're pleased to have as our speaker Dr. Daniela Minecan, an epileptologist with the University of Michigan Comprehensive Epilepsy Program. Dr. Minecan, can you briefly introduce yourself and talk a little bit about your clinical and research interests and talk about your experience with this topic?
Hi, Russ. Thank you for inviting me for today's discussion. It is a pleasure to speak for the foundation and to have, I guess, quite a few participants in tonight's discussion. So, as Russ was saying, I work at the University of Michigan. I've been here for probably over 20 years, but that includes my training first in pediatric neurology and then in epilepsy and sleep medicine. Over the years, I had accumulated a lot of experience with adult and pediatric epilepsy cases. And then in the more recent years, 5 to 7 years, I focused more on the adult epilepsy cases. I've been involved more with our intraop monitoring program, and I do a lot of the mappings in the brain tumor cases, and some epilepsy cases in the OR as well. And I started the NeuroPace program here, the responsive neurostimulator, which is a new, more recently approved device to treat patients with very refractory epilepsy. And we have now over 20 patients that have implanted with this. And my research, so that's very exciting. So my research is focused in the area of the brain mappings. We collect a wealth of information from the patients that have been implanted with the responsive neurostimulator. So that will open the door for more research in this area as well. So.
Okay, excellent. Well, and certainly your experience with both pediatric and adult epilepsy patients is going to be very helpful for tonight's discussion because the differential diagnosis can be quite different for the pediatric and adult population. So,
indeed, quite different, but very challenging, equally challenging for any age group.
Right. Okay, so let's dive right into that. So epileptic seizures can vary tremendously from one person to another in terms of their presentation, their electroclinical features, and underlying etiology. Because of this, it can often be challenging, like you said, to differentiate between epileptic seizures and other episodic conditions that involve transient symptoms. In many cases, the clinician who makes that initial diagnosis may have limited experience with epilepsy and limited access to diagnostic testing. In many cases, they haven't witnessed an episode and have to rely on descriptions from the patient or family members. So with all of that in mind, it's not surprising that misdiagnosis is fairly common. And misdiagnosis can consist of being diagnosed with epilepsy when you really have something else, or being diagnosed with something else when you really have epilepsy, or being diagnosed with the wrong type of epilepsy. So just very roughly, what percentage of people who are referred to a comprehensive epilepsy center would you say are eventually found to have the wrong diagnosis?
My impression is that overall probably 25 to 30% of patients will finish by having the wrong diagnosis from the patients that are being referred to an epilepsy center. And of course, sometimes it's a little less, but roughly we are looking somewhere there. So like a quarter, at the most a third of patients, but that's significant.
It is, yeah, definitely. And is any one of those three categories of misdiagnosis more common than another, or is it pretty evenly distributed between those?
I think that overall, my experience and what I've learned from other centers is that maybe it's more evenly it's equally misdiagnosis percentage-wise. Those that are diagnosed with epilepsy when in fact they have something that is not epilepsy or the other way around. Probably the category of patients that are diagnosed with the wrong type of epilepsy, that category is a little bit more than just 25%. And it doesn't have to be, when we talk about epilepsy patients being diagnosed with the wrong type of epilepsy syndrome, doesn't have to, it's not so easy saying generalized versus partial. Even amongst the various generalized epilepsy syndrome, there can be misdiagnosis, or when you look at different partial epilepsy syndrome, they can be mistaken one versus the other. And obviously these patients are being treated one way or another, but if you give treatment with a medication that is not broad spectrum to someone that has generalized epilepsy, they can be inadvertently making worse, so they can be precipitated to have more seizures. And on the other hand, if they are diagnosed with partial epilepsy and they fail more than 2 medications, they are not looked into whether they are surgical candidates. And another thing that is very important is certain generalized epilepsy syndromes carry a better prognosis versus others. So that's another area that is unfortunate when the misdiagnosis is made. So maybe this category, misdiagnosis, the type of epilepsy, the type of seizure, is a little bit more preponderant than the others. By not more,
right.
but a little bit more. That's my impression.
Right. And we certainly, when I talk with clients and family members, I often, many people will not have ever been told anything about their epilepsy type. They may have been told what types of seizures they have, but and those can sometimes be very vague terms. I have big ones and little ones and that type of thing. So yeah, I definitely think that kind of is consistent with my experience as well. So we'll talk later about specific conditions that epilepsy can be confused with, but can you discuss some of the most common diagnostic mistakes that are made when it comes to seizures?
Just like in anything in medicine, probably the one of the very common mistake is just to take for granted a diagnosis, like you are not the first physician that is evaluating a patient, and the patient comes and says, well, I have epilepsy and I take these medications, and you just keep refilling without investigating further. Another very common mistake is going back to square one, is the failure to get a good and detailed history. This is probably the most common cause that leads to error in diagnosis, and that's just not just in epilepsy and neurology, in any subspecialty. I remember, I think I was a med student when one of our professors, internal medicine actually, he was telling us, when you take the history of a patient, you have to investigate like you're investigating a crime. And you have to go back to the very beginning and reconstruct everything. So everything has to be very clear in your mind. So that's what we need to do. So probably this is one of the most common errors in diagnosis, failure to get a very good history, because the patient will always tell you a very good, very detailed history. Sometimes you need to ask further questions because some details may be omitted. The patient doesn't know how important they are. These days we have the luxury of asking patients and families to maybe videotape what's happening, and that's very, very helpful. And then another common error is when when we kind of misdiagnose something organic versus more psychogenic. That's very, very common.
Right. And how often do you see either over or under interpretation of the EEGs in patients who are referred to you?
So that going further into the EEG aspect, I think that unfortunately reading an EEG can be quite subjective because sometimes some findings are very subtle, and I see even in our group, we sometimes ask each other when we are not sure about a specific finding, especially if it's not often seen on a particular record. One of the biggest error in interpreting an EEG is to call something epileptiform, or what we call a sharp wave. It looks very sharp. And in fact is what would be a benign variant. So in other words, looks sharp but doesn't carry any implications for the patient. Then going to that's for interictal, and then going for the ictal recordings, it's not easy sometimes. There are epileptic seizures that are not associated with a clear-cut pattern on the EEG, and in those cases, erroneously, it was misinterpreted as non-epileptic, or sometimes is a rhythmic artifact, and that can be misinterpreted as a seizure, an epileptic seizure. And the other problem is that we don't always can review the same record that was read at a different institution or a private practice office, and we rely on the report. Because reading the report of an EEG is not sufficient. We should never take that for granted. So I personally either ask the patient to try to bring me a copy of the EEG that was done somewhere else, or I just try to repeat one here. And then EEGs can be very subjective to be interpreted. So I don't know, 40-50%, roughly half of the time we see errors. Some minor, some more with more significant consequences, negative consequences for the patient.
Right. Okay. So what are some of the consequences of misdiagnosis? Why is it so important to get it right the first time? The consequence, if you get the wrong diagnosis, then you go the wrong path. So you are going to pursue the wrong treatment. Someone with, for example, what we generally call non-epileptic seizures, but this non-epileptic seizure is a big basket. So someone with non-epileptic seizures is misdiagnosed as having epileptic seizures, so that patient can be treated years and years with anti-seizure medications. Or someone that doesn't have that does have epileptic seizures is misdiagnosed as something else and will delay the treatment. I'll give an example. Unfortunately, my first patient pediatric patient that I put through surgery, and later on, years and years later, he actually died. But when he was first referred here, it was after he had a grand mal seizure. But before he had that grand mal seizure, I think he was 7 when he had that grand mal. Grand mal is a convulsion or generalized tonic-clonic seizure. Prior to that, for about 1 or 2 years, he was seeing a psychiatrist because he was, all of a sudden, out of the blue, he would start screaming and yelling and acting very terrified. And it was interpreted that he has some psychiatric problem, and he was also very agitated, anxious. So he was somehow referred to a psychiatrist
interpreting that he has, I even don't know how he was labeled in psychiatry. And then when he finally had a seizure, he was sent here, when in fact he had what we call a malformation of brain development in the more posterior part of the brain, not the very back, a region of the brain that we call the parietal region, that can give someone seizures that are associated in the beginning, could be associated with this very unusual sensation, very complex sensation. So what the poor kid was experiencing, he was telling us that he felt that there was a ghost on his back, and that ghost was running after him and blowing on his back. And that's why he was screaming and acting so terrified. And then eventually, all these were seizures. So when they were getting so severe and back to back, he had a grand mal. So the consequence of having the wrong diagnosis, you're getting the wrong treatment, and can obviously have very negative consequences for the patients.
Right. So with all of this in mind, should comprehensive epilepsy centers work with their health systems to offer what I've sometimes heard referred to as first seizure clinics, where anyone who presents with a possible seizure, either in the ER or at a primary care physician's office, is automatically referred to an epileptologist? I imagine that could dramatically reduce misdiagnosis, but it might also overwhelm the limited number of epileptologists who work at the center. So what are your thoughts on this in general?
Yeah, that's an excellent point. Even here, we started creating this first seizure clinic, but then due to manpower, we haven't actually been running it the way we were planning. I think it would be great. It would be absolutely great if we can have more of these first seizure clinics, because at the end of the day, what is most important is to have the correct diagnosis and guide towards the correct treatment. It can get busy for the epileptologist, but it will eventually pay off, because you see the patient in the beginning when the complications are less and things are a little better and easier to handle than 2-3 years down the road when the damage maybe has already been done. So we should make everything possible to have more and more of these first seizure clinics. And the first seizure clinic doesn't necessarily have to be run just by an epileptologist. We can have in a dedicated epilepsy center one of the nurse practitioners run the clinic, and then with a supervising physician, and that should take a little bit the burden off the work from the epileptologist. But we should try and have more of these first seizure clinics, because even whether it's a nurse practitioner that works with the epileptologist or the epileptologist, those details in the very beginning can make a huge difference. Sometimes the first seizure is not the first seizure. Sometimes when the so-called first recognized seizure, when you take a detailed history, you realize that patient has been having seizures, like in my example, for a while, and then the picture is completely different. The approach will be completely different. So yes, I'm all for this first seizure clinic and put our efforts together so we can facilitate them and encourage them as much as we can.
Great. All right, so now let's discuss some of the many different conditions that need to be ruled out when making a diagnosis of epilepsy. First, can you briefly describe the differences between a provoked seizure and an unprovoked seizure, and discuss how this affects whether a diagnosis of epilepsy is made?
Absolutely. So first things first, what is provoked versus unprovoked seizures? Provoked seizure, when a seizure, if it's provoked, usually it's going to be a convulsive or a generalized seizure, but not necessarily. So provoked seizure means when a seizure occurs in the context of something else going on. Maybe someone is very dehydrated. It's very common, actually. It was during my pediatric residency. I was seeing this all the time in the summer. Maybe it's a young child that has severe vomiting and diarrhea. They get severe hyponatremia very quickly in less than 24 hours, and then they will have their grand mal seizure right there. So that would be considered a provoked seizure, where someone has a brain infection, such as encephalitis, any kind of encephalitis, and then that patient will have a seizure. So that's also provoked. Or it's very common in younger children to have what we call febrile seizures. A lot of young children, they respond to a febrile illness, especially when the fever goes up very quickly, with also having a febrile seizure in addition to whatever else is causing the fever. And typically the typical febrile seizures are between 6 months and 6 years. So all that is provoked seizure. And having a provoked seizure doesn't mean that you will develop epilepsy later on. Or you can be in a very unfortunate severe car accident and you'll have a head injury with it and you'll have a seizure right then on the spot or within the first 24 hours. So that's also a provoked seizure. So something happens before you have the first seizure. Unprovoked seizure when it's what we call out of the blue. Nothing else. The patient is completely fine. There is no history of anything whatsoever. No headache, no fever, no vomiting. There is absolutely nothing. The patient is in his usual, what we call usual state of health, and then they will have a seizure. So that's unprovoked. And it's very important when we see the first time a patient with the so-called first seizure to get a very detailed history. Was there anything else going on? Because we try to distinguish between the two because it has ramifications, again, about the management, what kind of investigations we do, and, of course, about treatment.
Right. And the diagnosis of epilepsy used to be 2 unprovoked seizures, but now it's changed a little bit. Can you talk about how the definition has changed?
Right. My understanding. Yeah. So now, if you have the diagnosis of epilepsy, and it doesn't matter what kind of epilepsy, we're just talking generally speaking about epilepsy. If you have more than one unprovoked seizure, that means you have epilepsy. However, if someone has 10 seizures in a day or several seizures in a day within 24-hour period time, that's considered one event. So if someone had a bunch of seizures out of nothing, and then they stop having further seizures, investigation, we are not talking about investigation, but no further seizures after that, that should be considered a single event. So once again, the definition of epilepsy, if you have more than one unprovoked seizure, that is the second one being at least 24 hours later. So right, that's
right. And then also the other situation would be if there's a single unprovoked seizure and some additional evidence that the person is at high risk for subsequent unprovoked seizure.
Yeah, that has ramifications for the treatment. That has ramifications. But just to make the diagnosis of epilepsy, if someone comes and they told you that I had a seizure last month and now I had another one, that should ring a bell that maybe that person has epilepsy.
Right.
And then you run the, obviously, EEG, MRI are the two tests. MRI could be negative or could show a lesion. But if the MRI, especially if MRI is negative, EEG could be normal and still that patient would qualify for the diagnosis of epilepsy. Right. And having said that, it's very important that the treating physician is explaining to the patient that the EEGs often are normal in between seizures.
Right.
a normal EEG between seizures does not exclude the diagnosis of epilepsy. That's very, very important. We actually started including this statement in our ambulatory normal EEG studies that we read. Because someone has a seizure or several seizures, the EEG is normal in between, and the patient cannot understand, so why do I need to be treated if my EEG is normal? EEG is not a perfect test. So yes, I've seen patients with very refractory seizures actually, and in between their EEGs can be normal. And of course, if we don't record a long enough EEG, we are going to miss some abnormalities. I don't know if we are going to talk about this later again or not, but I have a good example for that.
Okay. Well, go ahead, and you can mention it now, just so we don't forget.
Yeah. So the EEG, ideally, if someone has seizures and is for one seizure or more seizures, and especially unprovoked, and is evaluated for the first time, it's very important that that EEG is not run for just 30 minutes or half an hour. That EEG should be done for at least a couple of hours, and the reason is that capturing sleep during the EEG can make a difference in the sense that often or more often specific abnormalities such as those sharp waves can be seen especially during sleep or exclusively during sleep. I have seen recently a patient here, and it's clear-cut that by history he has epileptic seizures. There's no doubt about it. But he has refused so far to come in for monitoring to capture his events. And he's had 3 EEGs here as outpatient. I believe one of them was a long enough study, like a 2-hour study, but it didn't capture sleep. And I was the physician that saw him most recently in clinic with one of our fellows, and I decided, okay, let's do an ambulatory EEG recording. In other words, doing an EEG that can be done at home, and now we also have an equipment that has video, so we can see the patient at home. And I was completely dumbfounded by the fact that he has so many of these sharp waves in his sleep. They are very, very frequent. Like I would say 60-70% of his record in sleep is occupied by these sharp waves. Whereas in wakefulness, there's no focus, there's nothing. His EEG is completely normal. We did not capture any seizure, but we did see these sharp waves. And seeing these sharp waves and where they are located, I'm going to pursue that he has a repeat MRI, and it kind of gives you a little better idea what to look for and what region and this and that, whereas, again, a normal EEG does not exclude the diagnosis of epilepsy.
Right. That's a great example, yeah. So psychogenic non-epileptic seizures, and we mentioned this a little earlier, are commonly misdiagnosed as epilepsy and vice versa. So what are some of the common differences in presentation that can help differentiate a psychogenic non-epileptic seizure from an epileptic seizure? And what are some of the other important factors that go into making the correct diagnosis?
A very important topic actually, because a lot of patients are referred here as so-called diagnostic. In other words, we want to confirm or not the diagnosis of epilepsy versus non-epileptic psychogenic events. Sometimes the diagnosis is challenging because even the theory is there. There are some features that theoretically can help you distinguish a non-epileptic versus an epileptic seizure, but the theory is not easily applied in practice. And sometimes the EEG can be challenging to be read during a specific event. To clarify, epileptic seizure is the one that we can see an electrographic correlates. So EEG changes during the specific event, and the non-epileptic psychogenic seizure is the one where at the time of the specific event, the EEG remains unchanged. The psychogenic non-epileptic seizures are also paroxysmal events, but the main thing to keep in mind is that these are not associated with the abnormal brain electrical activity. The psychogenic non-epileptic seizures are not purposefully produced by the patient. They are not specifically induced. The patient is, greater than 90% not aware that the seizures are non-epileptic. Some patients are very frightened and anxious over having these symptoms. So, Now, theoretically, there are some features that help us think, well, maybe this patient has an epileptic, or maybe this patient is more like non-epileptic. So some of these features are the duration, for instance. So it's a typical epileptic seizure, whether it's a convulsion or partial seizure or other type of seizure, will not last very long. And we are not going into the whole subject of status, like epileptic status. So an epileptic seizure usually is, like a so-called petit mal or complex partial 1 minute, 2 minute, whereas a psychogenic non-epileptic event will tend to last a little longer than that. Even if someone has a psychogenic non-epileptic seizure that looks like a convulsion, will last a little longer than the typical 30 seconds to 60 seconds generalized convulsion. So duration is very important. The other thing is that presentation. Often the patients with non-epileptic seizures will have vocalization during the event or immediately after. Kind of complex vocalizations. Sometimes they will talk, this and that, whereas with an epileptic event, vocalization can be in the very beginning. Sometimes is not intelligible, especially is from the dominant hemisphere, and has no emotional expression. A very important other feature is the fact that epileptic seizures will tend to occur or are more likely to occur out of sleep. Some patients actually have exclusively epileptic seizures occurring out of sleep, whereas the non-epileptic psychogenic seizures will occur only out of wakefulness. And some patients will say, no, but I've had them in sleep. Well, the thing is, the patient wakes up. Unless you have an EEG running at the time to see that, what we see here in the monitoring unit is the patient will be awake first and then will go into the paroxysmal event. So we shouldn't rely entirely on the observation or the report that, but it happened out of sleep. No, there's some wakefulness just prior to the event. As a matter of fact, when we have patients here in our monitoring unit, they wake up and then they will have the event right then. I'm very concerned, even if we don't see anything on the EEG, I'm very concerned that maybe the patient has a specific feeling or the electrographic discharge where the focus is so deep that we cannot see it. So even if the EEG looks unchanged from an arousal, I'm still concerned that's an epileptic seizure. Then some patients with psychogenic non-epileptic seizures tend to have a lot of crying during the event, or they will close their eyes, which are things that are more rarely or never seen with epileptic seizures. Epileptic seizures will most of the time cause confusion, tiredness in the immediate after the event period, whereas the non-epileptic person will most likely have like side-to-side head movements or body movements involving more the trunk versus the limbs. There's a lot of pelvic thrusting. I've seen that commonly in non-epileptic, whereas that's very unusual in someone with epileptic seizures. Patients with epileptic seizures coming from the front of the head, the so-called frontal region, they can have a lot of motor. We call them hypermotor. They're very agitated, do a lot of motor movement during the seizure, but they will never have pelvic thrusting. Then the jerks, the so-called rhythmic jerks that you see in a convulsion, they can be kind of asynchronous in a non-epileptic event, and again, they will involve the trunk much more than the limbs. And then there is the argument about the memory recall. Patients with non-epileptic events will recall the sentence, whereas the one that has especially a complex partial seizure, they don't remember that. And of course, the gold diagnosis and the standard gold diagnostic test is video EEG monitoring, but that sometimes is not possible, either because the patient will not have the event in the hospital, they're too infrequent, or maybe they don't have the means to be monitored, they don't have insurance. Again, ambulatory EEG recordings can be done, so it's easier for the patient and the family for this kind of recording to be done in the home natural environment. Or sometimes even just a video of the event will give us some guidance. Again, semiology or presentation by itself should not be 100% taken for granted, but will give us some idea. So these are some of the kind of points that we have in mind when we decide epileptic versus non-epileptic.
Great. That was a lot of really useful information. Thanks. Focal seizures can involve symptoms that mimic certain psychiatric conditions. Can you give some examples and discuss how that differentiation is made?
Absolutely. So the patient that I was giving you the example earlier, he was misdiagnosed as being psychotic, so that's an example. Then some patients with seizures that are, so there are patients with seizures coming from the most medial part of the temporal region, so specific areas of the brain. And before they lose awareness, they will have just a sensation. So before the abnormal electrical activity propagates to a larger area of the brain, the patient can describe specific symptoms, and those are very valuable. So there are patients that really experience fear as a seizure. And sometimes that's all they have. They only have the fear. We call it like the ictal fear. So that's why they get very anxious, very nervous, almost like a panic attack. So ictal fear versus panic attack is a very common scenario. And I have patients, and then to complicate things further, patients with so-called temporal lobe seizures or frontal lobe seizures, they will have psychiatric comorbidities, depression and anxiety, and they have panic attacks. So that's very hard. Sometimes it's very hard to distinguish. I have a couple of patients, I don't know when they are having their seizures versus just anxiety from their medical problems. So that's definitely an issue, and it's important to distinguish when possible. Then there are patients that can have an epileptic seizure, but then in the period immediately after the seizure, they become very agitated, very confused, and their agitation can be so profound that they become psychotic. And so we call it post-ictal psychosis. So if someone develops this kind of symptoms in the immediate post-event, we call it post-ictal psychosis, sometimes can last up to a day. And with the same token, I've heard from several patients or their family members, actually mostly from their family members, saying that some patients, before they have a seizure, the day or a couple of days preceding the seizure, they will have a change in their personality and mood, and they become more irritable towards being a little more psychotic. So that's another thing. But they are still responding and all that, but then they will finish by having the seizure. So then there are patients that have seizures out of sleep with very complex behaviors, then we go into other area that, there are events related to sleep, but seizures that are occurring entirely out of sleep and have this complex behavior sometimes are kind of manipulated by certain patients trying to say, well, but I don't remember what happened. But those patients have significant other psychiatric comorbidities, and there have been examples in the literature about those. So those are some important things to keep in mind. But in a nutshell, a lot of patients with seizures will have psychiatric comorbidities. Some will have changes in their mood and personality before and after a seizure. Some patients have symptoms during a seizure that can be mistaken as a psychiatric symptom or something that is seen more commonly in depression, someone with depression or anxiety.
Right. And can you talk just briefly about like hallucinations, because that's also something that's commonly associated with certain psychiatric conditions, but in epilepsy it can be smelling, seeing, or hearing something that's not there. And my impression is that with epilepsy it tends to be briefer or more brief, and then also less likely to be complex hallucinations, although it can be that as well. Is that? Sometimes
can be, like I was saying with this patient, like if someone has
right, yeah.
So talking about the complex hallucination, if someone has seizures from this, what we call parietal region, which is a more posterior region to the temporal region, they can have this, what we call complex sensory symptoms / hallucinations. So that's a little more, it's more infrequent, and even then, these tend to be very stereotyped. If someone has, let's say, a seizure that's presenting with that, it's a very stereotyped thing, and I think it would be hard for someone that has just an underlying psychiatric problem to be so brief, stereotype, and I think auditory hallucinations are more infrequent, and they will never be complex auditory hallucination like someone with schizophrenia, for instance. So the auditory changes usually they are more like auditory changes rather than auditory hallucinations. There are patients that have seizures that involve a certain part in the temporal region, what we call the primary auditory cortex. Those patients will tell us that they have everything is muffled and kind of distorted. So that's completely different versus someone that has a very complex auditory hallucination, someone telling them to kill themselves. So that will be very unlikely to see in an epileptic patient. And then the olfactory hallucinations, specific unusual smell sensation when there is nothing around them to smell that. Like you said, usually are very stereotyped. It's always the same smell, cannot be different, very brief. Duration is very important. And then the visual hallucinations can occur only when the very back part of the brain, what we call the occipital region, is involved. And in that case, Usually it's a color thing. Patients will describe multicolor, bright colors. It's something that, and then that gets bigger and bigger and has this kind of concentric feature to it. When it gets bigger, goes bigger in circles kind of thing. So that's more, and it cannot be very, so it's not like I'm seeing a mountain if I'm by the ocean. So it's not like that. It's a very kind of maybe geometric colored gets bigger hallucination in someone with this the so-called occipital seizure. So that's very different than someone that has pure visual hallucinations.
Right.
So duration, presentation, the fact they are always the same. Go ahead.
Yeah. Several sleep disorders, along with some benign sleep-related phenomena, involve symptoms that can be similar to seizures. So what are some of the more common or notable examples, and how can they be distinguished?
So speaking of sleep disorders that, the sleep disorders to be distinguished from seizures, to me, the most common one is the so-called jerks during sleep. There are patients that are being diagnosed with myoclonic epilepsy, such as patients with the so-called juvenile myoclonic epilepsy, and they do have these myoclonic jerks, but they are during the daytime, they are not at night. It's very unusual to have them during sleep. So the thing is that a lot of people have these jerks as they fall asleep, or after an arousal during sleep, when they fall back asleep, they have these jerks. They usually involve just one limb at a time. It's very brief, will not waken the patient, is not as violent as an epileptic jerk. It would be more unusual to occur when the patient wakes up. So a lot of patients have jerks as they are falling, these myoclonic jerks that occur when they fall asleep or during their sleep, and by no means any jerk during sleep is seizure. No. Clearly an EEG will help, even though there's some muscle artifact on the EEG, but then just taking the history sometimes can help between the two. I wouldn't necessarily bring someone and do a 24-hour EEG to rule out seizures in someone that is clearly describing you the so-called sleep myoclonus. Then there are patients with all sorts of paroxysmal sleep-related conditions that occur out of sleep. All sorts of parasomnia, sleepwalking, sleep talking, and taking a good history again, combined with the lack of any other symptoms during wakefulness, will help distinguish. But if it's challenging or the symptoms are too profound during sleep, of course, running what they call a 12-lead EEG with a sleep study is very helpful. So the sleep study is important because it has several leads, like several leads that will be placed on the arms, legs, the respirations are monitored, heart rate is monitored, and then instead of placing 2-3 leads on the head, they can do like a full EEG placement or at least a 12-lead EEG placement. So seeing the normal sleep or normal wakefulness, if someone starts having sleep talking or sleepwalking, will easily distinguish between a sleep disorder versus a normal pattern versus a seizure. And I think the so-called restless legs or periodic limb movement disorder is more easily distinguished even by history, because usually people that have this condition, they usually have more their unusual movements, more like 4 or 5 o'clock in the morning, and then they are woken up by that. But again, EEG with a sleep study at the time would be a great way to help differentiate between the two.
Right. Right. And I can certainly remember my daughter when she was younger, 3-4 years old. She had night terrors, and I was working
Yeah.
at Epilepsy Foundation at the time, and I'm thinking, okay, I'm pretty sure these are night terrors, but part of me was thinking, are these focal impaired awareness seizures or complex partial seizures? Or so it can be very challenging for parents in particular.
And some of these parasomnias are very, very, how should I say, their presentations is very dramatic. I remember years ago, as a sleep fellow, we were presented with a video with a young child that had this repetitive head banging behavior. So it was occurring during a specific time of his sleep, and he would just all of a sudden sit up in bed and start banging his head. And it was terrifying for the parent to watch. So he was eventually referred here. So yeah, they can be very dramatic, these parasomnias.
Right. Okay, so both migraine and movement disorders can involve similar symptoms to certain epileptic seizures. However, in most cases, the symptoms tend to last much longer than a seizure, and typically enough to tell them apart. Are there any examples you can think of, though, where a differential diagnosis is more challenging when it comes to migraine and movement disorders?
For migraine, for instance, there are patients that will have visual changes at the very beginning where preceding the migraine. So important to remember any visual changes in a patient with migraine will be black and white. There shouldn't be anything colored. Black and white, and it's usually dots or spots. So it's easy. If someone says, well, I have this black and white spots that I see, whether they're in a specific region of their vision, like a certain visual field, and then they say they will develop a headache, that should kind of easily guide you that's not a seizure. Once again, patients that have seizures and have any visual changes will not be black and white. It's not unusual for someone with a migraine to be so extreme. There will be some impaired awareness at some point, but taking a good history, in those cases it will be impossible not to elicit at some point a history of a headache. It's very unusual, but it can happen for someone to have just symptoms that are occurring at the time of a migraine, but then sometimes they don't have the headache, they just have the other symptoms, what we call the migraine equivalent. So taking a good history, I think that should be very, very helpful. And of course, a migraine is much longer than a headache, and it's unusual to have impaired awareness. And then patients with movement disorders, a lot of the patients with movement disorders, chorea, tetanosis, dyskinesias, it's unusual for those patients to have just unilateral movements. They are usually bilateral, and they have completely preserved awareness. Someone that has any kind of bilateral movements with their seizures, they have to have impaired awareness. There's no other way around it. And like you said, duration is much longer in a movement disorder, if not nearly continuous, versus someone with an epileptic seizure. And lastly, the patients with movement disorder, usually their movements tend to go away when they are asleep, whereas an epileptic seizure will occur out of sleep, out of wakefulness. It doesn't matter.
Right.
I think these are important things to remember to distinguish between the two, between these categories, I mean. Yeah.
Right. So transient ischemic attacks, or also known as TIAs or mini strokes, can result in temporary loss or weakening of functions that can mimic focal or partial seizures and also mimic postictal symptoms. So what are some of the key differences that can help with this diagnosis?
Yeah, so usually transient ischemic attacks or the so-called mini strokes They are indeed a mini stroke. It's just they last a much shorter period of time, and usually they will not be associated with any brain injury as opposed to stroke. So most of these mini strokes will have more of what we call negative symptoms. So by negative symptoms, I mean, positive symptom is when you have like an unusual movement with an arm, like a myoclonic, like a jerk. Someone with a TIA will have, all of a sudden, they will become weak on one side. A patient with a seizure can be weak, but it's very unusual to be weak during the seizure. It can occur during a seizure, but it's more unusual, and it's just with specific type of seizures. And even when they are weak during a seizure, that will be brief, right? Like 30 seconds to a minute. The TIA will last longer. So the TIA will last less than 24 hours, from what I remember, but usually will last a little more than an hour. So it could be half an hour, 1 hour, a couple of hours, and then gradually the symptoms will improve. Whereas this pattern is not seen in seizures. The seizure will have the symptom for a minute, less than a minute, 5 minutes at the most, and then it's usually a positive symptom, and then you'll have the negative symptoms. So talking about the weakness that someone can have after a seizure, it's unusual to be weak on the whole side of the body. So usually someone with a transient ischemic attack or with a mini stroke, they will be weak on the whole side of the body. Because they will be weak because their the transient ischemic attack or the stroke is associated with weakness because of the vascular territory, whereas with the seizure, it's a different kind of anatomic area. So then someone with a seizure is not going to be weak on the whole side of the body. Usually they are weak with a hand. That's typical. The so-called thought paralysis. It's more unusual that if the seizure was big enough, they can be weak on the same side of the face and the arm, but not the leg, because the leg is on the medial aspect of the brain, whereas the arm and the face are on the lateral aspect. So the seizure follows the anatomical area, whereas the mini stroke will follow the vascular area. So that's why the distribution is different. So it's usually this negative versus positive symptoms, duration, and the area that is involved in the body. Then it's unless someone has a really big stroke. I think with transient ischemic attacks or mini strokes, it's unusual to have any kind of impaired awareness, whereas a lot of patients with seizures, even if they're still aware of themselves, they're not that aware of themselves. But the patient with TIA, they are very sharp. They know exactly what's happening to them. So that's another thing to keep in mind. I think these are the major things between these two categories.
Yeah, and I imagine in some cases it might be a little more challenging if you don't witness the seizure itself, because a lot of times if you're a family member, for example, maybe you miss the actual seizure and all you see is the post-seizure.
Right.
And so that.
But then even if correct, but even, I mean, this is very true, but even if someone is weak after a seizure, typically, this focal weakness after a seizure should improve over half an hour, 1 hour kind of thing. It shouldn't last. It's a little unusual up to 24 hours. But again, if someone has seizures back to back, it can last longer. So it can vary from patient to patient. And I think it's more common in children versus adults, but any age group.
Right. Okay, so certain cardiovascular conditions and events can also mimic epileptic seizures. Can you discuss syncope, arrhythmias, and other cardiac conditions and how to distinguish them?
Right. Yeah, that's a great topic actually by itself, because often patients with syncope will simply faint. So they will just pass out at the end of the event. So it's hard to tell what provoked that. So I think that the syncope, vasovagal kind of event is the most common kind of paroxysmal cardiac event that can raise the concern of seizure. Patients with a cardiac syncope, they will probably have some premonitory symptoms before they lose awareness, or they fall, or they even have a seizure at the end of it. So most of the time, this syncope will not occur when they lay down or sitting. Most likely, it will happen when they stand abruptly, or in a standing position after a period of time, or in younger patients, like younger children or teenagers, sometimes they can have like a painful thing, so they can go into this kind of vasovagal type of reaction. So most of the time, it will be the position where it happens. Then, after which it happens, standing versus laying down. Do you have any symptoms before you pass out? Does your blood pressure change when you stand abruptly? Because that can provoke a syncope too. And of course, the evaluation after that with an EEG. Sometimes we need to monitor these patients if the history is not easy or clear cut. Things become a little more complicated when someone describes that they are having a convulsion, like a brief convulsion, when in fact it was provoked by a syncope, and they don't remember, or they ignore those premonitory symptoms or the circumstances when it happened. And I think it's more common in younger patients, in children, to have a syncope, and then if it's too prolonged, the cardiac event, the hypoxia is so bad that they will have a seizure at the end of it. And usually that seizure should be a grand mal seizure, not like a focal seizure or something else. Then I remember, but then the other thing is that some patients will have epileptic seizures, and you see nothing on the EEG. They don't feel anything, or maybe they feel something very vague, and the epileptic thing in the brain will trigger them to have an arrhythmia. And I think I have an example for that. Years and years ago, there was a patient that was brought to the adult monitoring unit, and the question was this, syncope versus seizure. So I remember the video very clearly. She was knitting. She was sitting in an armchair, and she was knitting, and all of a sudden she felt something. At that point, her EEG continued to be normal, and her EKG, so her heart rate, the monitoring of the heart rate didn't change at all. But she felt something because she went and she lay down in bed. And then after that, we noticed a change in the heart rate. She became progressively more bradycardic. And then she started having, there were some changes on her EEG, but it wasn't anything very localized. I think what we did with that patient, we involved cardiology, because sometimes things can be so complex. It doesn't matter if someone has seizures, but if they go into a very slow heart rate, like severe bradycardia, or what they call asystole, in other words, you are missing a heartbeat for too long, then you need a pacemaker. So I think we involved cardiology, and they put a pacer in that patient, and we also started treatment for her with a seizure medication. So sometimes it can be very complicated. And to finish with that, there was a patient that he underwent epilepsy surgery, and we finished by placing a neuropace, a responsive neurostimulator, because he didn't qualify for epilepsy surgery. But we noticed when he was monitored with invasive monitoring, with electrodes being placed on the brain, that he was going into asystole. So he got a pacer from cardiology, and the seizures never progressed to the severe seizures he was having before, because he wasn't going anymore into the asystole. So even though he continues to have the epileptic seizures, they were relieved and improved. They were improved just by that pacer. So I think this is the most common. The arrhythmia and the syncope are the most common cardiac problems that can create this confusion with the diagnosis or complicate matter in a patient with epilepsy.
Right. So epilepsy in older adults is more likely to involve vague symptoms and prolonged postictal periods. So what are some of the key challenges in correctly identifying epilepsy in older adults?
Yeah, that's more challenging indeed sometimes, but no matter how vague the symptoms are, the seizures in an older person will still have the same features. So I think the best is to instruct the caretakers or family members that spend more time with them to observe them for as long as they can, to try to capture these paroxysmal events that are in fact seizures. The prolonged postictal period, that can be helped with a better anti-seizure treatment. And sometimes, or quite often in the older people, we don't see on the EEG, like in the younger patients, the so-called sharp waves in between seizures. And it's not so easy to monitor these patients in the hospital. So if you cannot even monitor at home, we look for more subtle things on the EEG, like very frequent focal slowing in an older person with suspicious events for seizures should make you even more concerned that that patient has seizures. And again, doing an ambulatory EEG probably would be very helpful, because we can do up to 6 days now. We do 3 days, and then the patient has to return to get a new battery, and then we can do another 3 days if distance permits to drive to the center. But, a good observation and history by the caretaker and the family, and paying attention to more subtle details, clinical EEG, and adjusting the medications and taking into account the fact that some seizure medications are too rough for this age group or have too many interactions.
Right. And it certainly is complicated even further when older adults have multiple health conditions that they're dealing with
Absolutely, yeah, because the symptoms can become a little more fuzzy, what is causing what, but just nailing down and taking a very, very good history, you should be able to identify some features that push you more towards an epileptic event.
Right. And similarly, recognizing epilepsy in young children can be challenging, because there are a wide range of behaviors and neurodevelopmental conditions and physical conditions to rule out, and it's further complicated by the fact that young children may be very limited in their ability to communicate what they're experiencing. So can you talk about some of the more common things that need to be ruled out when diagnosing epilepsy in young children?
Absolutely. So babies infants, young children, they have all sorts of paroxysmal events that can mimic seizures, but in fact are not seizures. So once again, history, and by history I mean not just what's the description of the particular event, details, when does it happen, does the child have any other condition, things like that. So putting everything into context. One of the very devastating type of seizures in young children is the spasms, and I'm pretty sure that several people that are listening to us tonight have heard about these infantile spasms, where spasms are one of the most frightening things to watch. Well, there are children that have this, there are infants or very young children that have these spasms. They look like they just have these spasms, but they don't have an electrographic correlate. Sometimes they can have just brief jerk, not a full spasm, just a brief jerk that can look just like a myoclonic jerk, in other words, seizure, but it's not. So for those children, for those babies, the single most important thing is an EEG. And sometimes actually following up over time is also important because their brain changes. Sometimes we say, oh, but there was nothing on the EEG, the baby is fine. Well, repeating that in 2-3 months can confirm that in fact it wasn't what we call epileptic spasms. So all sorts of jerks, spasms can be benign or not have electrographic correlate in the beginning, but in fact they are epileptic spasms. So then there are all sorts of metabolic conditions that can present with paroxysmal events. So again, putting things into context and running an EEG would be helpful. And speaking of putting things into context, there are children that have a number of conditions that fall into that: pervasive developmental disorder, autistic spectrum disorder, and they can have paroxysmal, unusual behavior, screaming, like a rage attack or something. So that's challenging because you cannot even do an EEG on those. But I think just observing, trying to videotape, trying to have a proper diagnosis of the underlying behavior should guide the clinician towards the right. But I admit it's hard. In patients that have this pervasive developmental autistic spectrum disorder, sometimes it's challenging because their EEGs can be abnormal, but in fact they will never have a real seizure in their life. So those are more challenging cases sometimes.
Right. Yeah. Definitely.
Especially when they occur. I have a patient, and he's a little older now, but obviously he was diagnosed with autism when he was younger. He's older than 18 now. His behavior due to autism is getting out of hand. It's very challenging for the mother to find a psychiatrist that can handle the medications. Then the young adult now, he started having seizures. I would like to do an MRI on him, but mom, the only way we can get that done is under general anesthesia, so mom hasn't decided to move forward with that. It's impossible to do an EEG, so the only thing we can do for the time being is to try to treat the seizures and to find a good psychiatrist, but he has both. Now, luckily, his seizures are very different than other type of behaviors he has, but that's not always the case.
Right, yeah, it can certainly be very difficult to distinguish between that, and certainly, like you mentioned, the ability to videotape events is a huge tool that we didn't necessarily have 10 years ago or 20 years ago. So
a huge tool which can be uploaded now. Most centers, or more and more centers, have now this EPIC system, and I know it can be uploaded from the patient's phone to this system. So it's a safe way of sending the video to the caretaker, not via an email. not via an email. Or, go ahead.
That's using like the portal, basically, the patient portal?
Yes. Mm-hmm. Yep.
Okay, great. Yeah. All right. And as important as EEG and MRI are in epilepsy diagnosis, patient history is perhaps the most important diagnostic tool.
Absolutely.
But sometimes describing episodes can be challenging. We just had a PhD student at U of M who worked with us on a project called Voices of Epilepsy, and it was talking one of the podcasts where there were interviews of patients with epilepsy, talked about just how vague some or hard to describe it can be for certain seizures. So what types of details, I guess, when you're asking about what is the seizure involved and what the actual symptoms of the seizure, what types of details are most helpful when you're trying to figure out what was going on?
Yeah, I always try to understand, I try to get such a detailed history so I can picture in my mind exactly what happened from the very beginning. So often people are, eager to describe a lot of symptoms. So I say, okay, wait a minute. We need to start from the very beginning. So first of all, I want to know exactly what were the circumstances, what was happening at the time, and again, asleep versus awake. Then I want to know from the patient. On one hand, I want to know from the patient if they felt anything or if they remember anything whatsoever before the event, or what was the first thing they did remember after the event was over. But I really, really, really insist on what did you feel? What do you remember? If you remember anything whatsoever. And then I also ask, did you ever had this feeling before? And that's also very important. I'll tell you in a minute why. So trying to find out from the patient exactly if they remember, I want to know exactly everything they remember from the beginning to the end. If someone was with them, I want to know what was the very first thing that they saw, and I usually tell the person that accompanies the patient, try to tell me so I can picture everything in front of tell me exactly what you saw, second by second, not just, he was jerking. I don't want to hear the term jerking. I saw the hand moving. If there was any motion, I tell them, show me exactly what you saw, and I ask the person to show me exactly what they saw. So I try to go into the very details so I can it's like in a puzzle. You want to put all the puzzles back to back to back and no piece missing. And then, like I was saying a minute ago, it's important to ask the patient if they've ever experienced any of those sensations or feelings before. I saw a girl last fall, or this fall a year ago. She had her first grand mal seizure, and then talking with her, she was describing me this kind of heart racing sensation and a little bit of anxiety that she had right before the seizure, but then she didn't remember anything about the seizure. So then I asked her, so did you have this sensation before? Oh yeah, I've had that for the last couple. So then she started giving me details, and then I realized that she in fact was having seizures for the last 2 years. She never had any impaired awareness, and then it culminated in this seizure. So history is very, very, very important from the patient and from the caretaker.
Right. All right, so looking at the time, I want to open it up for questions, and then just remind everyone to please mute your line if you're not asking a question. Okay, who would like to get us started with a question?
Hi, this is Travis. I just would like to bring up the topic of driving in seizures.
Yes.
Say hi to Dr. Minecan.
Hi, Travis.
Ross, too.
Hi.
Do you have
is there a
specific
question?
questions?
Yeah. How many states can you not drive in with seizures, or is that a federal law?
Well, I've been in the state of Michigan for over 20 years, so I'm very familiar with the law here in Michigan, so I can speak for Michigan. So the law here is that, and maybe Russ knows more about this than I do, but what I know and what I tell my patients from my perspective is the following, that if you have a seizure with impaired awareness, and actually if you have any kind of episode, it could be a different cause. If you have an episode where you had impaired awareness, unless it was something provoked and you know it's not going to happen again, you cannot drive for 6 months after that. Now, talking just about patients with seizures, so we tell them if you have seizures with impaired awareness, you cannot drive for 6 months after that. There are patients that they've had seizures for a number of years, and consistently their seizures occur out of sleep, like 100% out of sleep. After a while, we try to ease and make life a little easier for them and tell them, okay, I'll let you drive, but I'm going to say that every year we revisit the subject to make sure that nothing has changed, because seizures behave in a very strange way and sometimes they can change. So one category, if seizures after a number of years occur just out of sleep, those patients can drive, and granted they shouldn't be tired when they start driving. And then there are patients that have seizures that involve just a little bit of jerking or movement on one side of the body, or only some sensations on one side of the body. Those patients can drive as well.
Right. And as far as other states, there are some that have a year restriction, others it's 3 months, others it's 6 months, like Michigan, and then there's a few where there is no specified time frame. And it is basically up to the neurologist and the patient, and there may be a medical review board in some cases as well. So it is different from state to state, but it's certainly worth knowing if, for instance, you're thinking about where you'd like to settle and you have a type of epilepsy that's likely to last for a long time, then, that would be certainly something you'd want to consider is, what are my transportation options going to be? Maybe consider if, seizure control has been a challenge, maybe consider moving somewhere that has a really good public transportation system. So, other questions about differential diagnosis, or, how to figure out what the particular episode was?
Hi, my name is Beth. I have a daughter who's 7. She has a she's a rare genetic disorder, but she's diagnosed with epilepsy as well as a host of other diagnoses. And so it's really hard to wrap our head around the epilepsy, because she does have some severe behavior. And during these episodes, we've had other people who have been with her ask us, could this be a seizure, because she's completely unaware of what she's doing, and it can be very violent, and she's only 7. So I was just wondering how, at the very beginning you were talking about that gentleman who had that, weird, behavior.
Sensations, yeah. Mm-hmm.
Yeah, is there, how do we, because we do have an epileptologist, we also have a behavior involved. She also has a host of other specialists involved in her care who are all amazing providers, but I feel like we're constantly going at the behavior medication side, and we're not finding any solutions at all. And so I don't know, how do we, or is there any way that we can try to, as parents, try to help or, address this as a team, or is there any way that we can communicate this to try to find a way to better her quality of life?
Right. I understand that. So first of all, it sounds like your daughter, unfortunately, is a very complex case, very challenging. But it would be important, I think, to distinguish, to know, like, for instance, the violent behavior, is that part of her medical problem? Is that a consequence of the seizures, or is part of a seizure? Like I was saying, patients with seizures and other medical problems, and I don't know what other medical problems your daughter has, but often patients just with seizures, they have very complex behavior. They have, their mood is different, their personality is affected, and it's a whole other subject. Why is that happening? So once again, to know exactly, even though it's complex, this violent behavior, is it just during the seizure? Is it immediately after the seizure? Or it's part of the background kind of thing because of the whole thing happening to her? Then it's important to choose seizure medications. Some seizure medications can aggravate certain behaviors. There are certain anti-seizure medications that are more helpful and better for certain behavior. So the choice of the anti-seizure medication is important. And so that's also kind of, generally speaking, the diet and the sleep are very, very important. Vitamin D is very important for patients with seizures. If your daughter is not already taking vitamin D, you should talk with the epileptologist and with the primary care doctor, because she needs to take it on a daily basis. That's a must, anybody with taking seizure medications. And it seems that vitamin D can, or the lack of vitamin D has a lot of negative consequences, including depression, not just broken bones and osteoporosis. And then, sometimes I encourage my patients to go for a second opinion somewhere else, because sometimes a fresh pair of eyes can make a difference. And I don't know if I answered part of your question or if you...
Yes, that's super helpful. Yeah, thank you. I really appreciate it.
I think that's a really good point, is that, I think sometimes people might think that they're going to offend their neurologist or epileptologist if they seek a second opinion. But just like you said, a fresh set of eyes can sometimes, notice something that wasn't noticed, or a different perspective can sometimes be a breakthrough. So
absolutely.
So yeah. Okay, well, I'm sorry we didn't have quite enough time for more questions. We are out of time, but if anyone does have any additional questions, certainly feel free to email me, and I can always, if it's something I can answer, I'd be happy to, or if it's something that relates to this topic, I could always check with Dr. Minecan about that. So
absolutely, and I'll be happy to follow up with you.
Great. Thank you so much. And thank you so much for your time and really beneficial and fascinating discussion. I imagine this could be helpful for even medical students because it was very, very, very well done. And hope everyone else enjoyed it and found it helpful. And thank you all for joining us tonight. And we'll talk with you all soon. If anyone does have any questions, certainly feel free to give us a call at 1-800-377-6226 or visit our website at epilepsymichigan.org. Thanks again, and we'll talk to everyone soon.
Sounds good. Thank you, Ross. Thank you very much for the invitation, and good luck to everybody.
Thank you.
Bye.
Bye.